I'm Dr. Sònia Travé Huarte. I've done a PhD at Aston University, so now I specialize on different treatments for dry eye, when to change from one to another, how to subclassify that dry eye. When we start with testing the ocular signs, one of the first tests that I do, it's either the breakup time, tear meniscus height, could be blinking analysis or osmolarity. So in this case in here we have the osmolarity. So what we're doing now is we're checking the osmolarity. So I normally explain this to my patient as the saltiness levels of your tears. So the more saltier they are, the more damage they can produce in the surface of the eye. If there's less aqueous layer, maybe we have more electrolytes, more salts, and that's what actually damages the surface of the eyes, then releasing cytokines and then releasing all these inflammatory markers in the surface of the eye. The only thing that we do is we just open this, and when it beeps, it's ready to take the sample. So we normally turn a bit the patient this way, tell them to look up and away, and I rest like so, and I just rest, trying to get onto the tear prism. For us to have a positive diagnosis of dry eye, we need the signs and we need the symptoms, but just with one sign, it is enough. And then you have about 2 minutes to normally get the measure or the sample, and then we just slot it in here, and in about less than 10 seconds, it gives you the result. That reading should be below 308, or there should be less different between eyes than 308 milliosmoles per liter. So that's the ideal. Anything that's more than that or a greater difference in between eyes, that is a positive sign of dry eye. In this case, we have 297, so it's not too salty. We can do the breakup time. I tend to do it non-invasively. I always prefer not putting fluorescein in because that's not the reality. Our patient doesn't walk around with fluorescein. So I use normally a Placido disc-based method to assess that breaking up. The TIFOS used to, the diagnostic criteria is telling us that anything that's below 10 seconds, it could be positive of dry eye. Now, nowadays, those 10 seconds seem to be very hard to get. So you'll see that most patients probably don't even hit these 7, 8. It depends on the type of patients that you're seeing. So the first thing that I do is I always want to check with infrared light, because I don't want to shine too much light at the start. I need to understand what our patients are actually seeing. If there's too much light, we could have more tearing, we could have more blinking, and that's what we don't want at the start. So the first thing, I always do something that the patient does not know that I'm doing. So I record them for 30 seconds just to see how they're blinking, but I don't tell them. I said, oh, I'm just focusing the device for 30 seconds. If they're blinking frequent, if they're not blinking frequently enough, if they're not closing all the way down. So we've seen that with this patient, we don't have sometimes a full closure, and also the patient's blinking quite regularly. If there's a lot more blinking, it could be that the eye needs to replenish more for whatever reason. Could be that there's an issue with the different layers on the tear film. So that's what we'll be looking into in a bit more detail. Also, in infrared light, I take a picture to measure the amount of tear prism that we have. So I normally capture an image after a couple of blinks. And what I do is I add calipers in here from the bottom of the eyelid to the top of the tear meniscus. I normally take about 3 measurements, about 1 millimeter per side, and we have about 0.14 on average on that eye. So what we know is that less than 0.20 millimeters, it's probably on the lower end, so there could be something going on with that aqueous layer, or could be something with the lipid layer, and that's why the tears are evaporating. So we'll be looking into all of that in a bit more detail. So as you've seen, I've started with the less invasive test. So we started with infrared light, and the next thing we'll do is we're going to put actually also still in infrared light, we're going to do the breakup time. So the breakup time in here is automated. So what I'm going to do is I'm just going to closely put that together and follow the instructions on the screen. So if you can blink twice for me, Jeremy, and hold it open for as long as you can, that's it. What we don't want is the patient to open the eyes wider than they normally do, because otherwise the breakup time will change. And what we're seeing here is if there's any disturbance in between the lines, when one of the lines sort of like goes a bit more on top of the other, that's when the device will detect it as a breakup time, or the first breakup time. The other thing is this device records the breakup time for about 24 seconds. So if it has not happened before, then the video will stop. You can blink now and relax. It will tell us in here when the first breakup happened, if it happened. So in this case, there's been no breakup. So we have about 25 seconds of breakup time, but we normally do it 3 times because we need to do an average of all of them. So 2 blinks for me and stare The other things that we have to be aware in the meantime, I look as well at the lids and at the lashes, make sure that there's all the lashes, if there's different lines of lashes, if there's any changing on those lashes as well. And I look at the rings. All topographies, most of them, are placidodisc based. So what we're seeing is the reflection onto the tear film and then the cornea. So apart from the breakup time, you can also see if there's any irregularity within the corneal shape. So this one we have about 18.35 seconds. So the surface is quite well protected. And we'll just do that once more. 2 blinks for me and stare. In the meantime, I also look at the tear prism all along the lid margin. This way we also see if there's any irregularity within the tear prism, because that could tell us if there's any issue with the meibomian glands maybe pulling from within, and that's when you see that notching, or if there's any sort of like rounding of that lid margin. And then the third breakup time, 22 seconds, 0.75. So that's good, it's quite well protected. The next thing that I do is I change light and I go to very bright light. And this way I will be able to see the patterns of the lipid coming up and down. So that's with the lipid layer pattern. So it's going to be quite bright now. And I increase the magnification to see things in a lot more detail. Here we have to be very precise, because if we pull far too in, we're going to see clearly the mires of the cornea, but that's not what we want. We need to be a bit closer to us, and that's when we have the lipid layer. So I normally record about 15 seconds, and I tell my patient to blink from time to time. So I see the oil spreading up, and if we blink again, so we can see that it's quite colorful towards the bottom. We have a bit of a wave pattern here, but also the patient's not fully blinking. So if you can do a full blink for me, that's it. Perfect. So we're seeing that there's some color in there. The color fringe pattern tends to be the most protective pattern, but we could also have that when the oils are too much, they might not spread evenly. So that could also be an issue. So it doesn't mean that always very colorful means good. It means sometimes it's not spreading well enough, depending on the viscosity of those oils. So now that we understood a bit more about the pattern of this eye, which is again a color fringe, I'll be looking also onto the redness of the eye. So I just look into there. They're just for me to understand, or especially if they're in any medication or any steroids to decrease inflammation. I just want to follow that up. So we have here the limbal redness, and we also have the conjunctival redness. This is in a grading scale. It's automatically done. So it puts the eye of our patient all along on the scale for both bulbar and retinal. So the tests that I've just explained, they're only for diagnosis. Now we're gonna go on to that subclassification and the tests that you need to do for each of them. In here, we have sort of this wheel of both evaporative dry eye and aqueous deficiency dry eye. And what we know here is that the inflammation, that tear hyperosmolarity, that damage, it's happening in the 2 subtypes. So there's no specific that one will have something higher or something lower. Once you've entered to that vicious circle of dry eye, you can have all of this. Now we're going to walk through the different types of tests that we need to do to understand each of the things. So the next test we do is the Inflammadry. So we need to understand with some of our patients how much inflammation our patients are having, or if they're having inflammation at all. In this case, we would like to see how much inflammation is in that possible dry eye. So we have a cassette and a collector, and then we have the solution, and we open the 2. And to take the sample, we're just going to use this bit, which is what's going to be in contact with the patient's eyelid. So the way that it works is we need to ask our patient to look up, and then we're going to bring the lower lid down, and we gently touch in there, 5 seconds. We do the same thing onto the middle bit, and then we do the same thing towards the nose. This tends to be a bit more uncomfortable for the patient. And then we do the same thing again and let them blink a bit. And again, same thing here, and just once more in here. Until then this glistens a bit, which means that it has picked up those tears. And then we put it all together like so. We press it well, and then we just put it like so. And then in about probably 20 seconds or so, there's going to be the liquid coming all the way up, and then we'll leave it flat for about 10 minutes, and then it will showcase, same as a pregnancy or COVID test. No lines, it's negative. 2 lines would be then positive. You can have a weak positive, you can have a positive, a strong positive. And then that's how we'll be seeing the inflammation. So as you can see now, the cassette is getting all the liquid that it needs. So normally I wait till it goes past that line. And once we have about there, we'll take that out. We'll just close it like that. and we'll just leave it flat for about 10 minutes. So at the moment, because we only have the blue line, it means that it's negative, because otherwise we would have the red line. If we would have the red line, that'd be a positive marker. So in this case, we don't have any inflammation in the eye. So we'll be looking for other things in terms of staining, or even in the corneal nerve imaging to see if there's any damage or any inflammation in there. Regarding the classification for evaporative dry eye, it could mostly be because of the meibomian glands. So there's that evaporation, and we need to test what those oils are doing in the surface of the eye, how they're coming out of the glands. So the report from TIFOS, but the first one back in 2011, that's the meibomian gland report, it tells us how to grade things and when to change from a mild condition to more moderate condition. So things that we need to look is that the oils coming out, how are those oils, if they're from more transparent to more cloudy to more inspissated. Also the volume, how much volume is coming and how much pressure you need to apply to get those oils out. We also need to look at the lid margin to see if there's any plugging of the glands, to see if there's any telangiectasia or changes in the lid margin. So it's not only the meibography and the images, it's the contents and everything that you're looking. It's a whole together. We have to look at a more holistic approach. Things that we can do or tests that we can use to help with that subclassification of evaporative dry eye. So we normally assess the glands. As we said, there's different types of devices that we're gonna walk through in a second. Just to, that could give you some types of different images. Infrared, they have to be all infrared. You can also express the oils in a diagnostic manner, just to see how they are and the amount of pressure that you need to put for those oils to come up. Then looking into the blinking rate, the closure, that could also tell us maybe there's too much evaporation. That's why our patient needs to blink so much. And then looking always at that lid margin and that displacement onto the lid margin. But after those, we would go on to the staining. So the first one, with fluorescein, there's plenty of grading scales that you can use. As long as you use the same one and you're consistent, that's fine. But TIFOS does too is telling us that within the cornea, if you see more than 5 spots, that is already a positive of dry eye. Versus if we move to the next one, which is lissamine green, those are 9 spots on the conjunctiva. So we have to be very careful with lissamine because it can help us a lot just to see friction, just to see damage. But we need to make sure that we see that we know that what we're counting are spots, not pools of lissamine, because we might have pools if we have lip cough, if we have any other lip related issues, but what we're looking at is those little dots onto the conjunctiva. So the next thing we'll do is we'll check for ocular surface staining. So we're going to use fluorescein and lissamine green just to see if there's any damage onto the cornea and conjunctiva, but also within the lid for the lid wiper epitheliopathy. So with fluorescein, we just put drops in there and then we just shake the excess off. And then we go and put it just out the outer corner. So I just make our patient look up and I just gently touch in there, because the more I touch, we can actually create some damage, and then we will not going to know if it's us or if it's something that the patient already had. So the next thing we'll do is lissamine. With lissamine, what we need to do is we actually need to put a very big drop. So we need to make sure that the dye fully eludes. So the way that I do it, I normally tell my patients to keep the tissue close to the inner corner of the eye, and I hold it on the tissue at the outer corner, because otherwise when they blink, the green goes down the cheek, and they're not too happy when I do that. So put a bit in there, and we just make sure that it goes back and forth so that we have the full eluded dye. So we need to make sure that we can see the full drop. So that's the whole thing that's going to go into the eye of the patient. So if you're going to hold the tissue in the inner corner of the eye and looking up and away, I'll just put a big drop right in here and blink, because otherwise when the patient blinks it's going to go down the cheek or all the way up, as it has happened right now. So if you're going to close your eye, so if you sort of wipe it out fast, it will not stay that much, but otherwise it will rest in there for quite a bit. Otherwise with warm water it will go. So normally what I do is, if I want to have more visualization, you can always change the exposure or change the gain to see better what's happening in there. So we might have probably some staining there. One of the things that I tell my patients is to carry on blinking just to see what's going on. Another thing that can happen is that you see the reflection of the tear film here. So I always tell the patients to look up just to see if actually what I was seeing there was reflection or not. So actually those dots, very, very tiny dots in here, they are from some staining dots. So we have just a tiny bit in here, a couple in here, and a couple in there. If I tell my patient to look to the right, we can even look at the sclera just to see if there's any dots of staining, as we also have. Normally that showcases more with lissamine. And then if you look to the other side, so normally TIFOs do tell us that if there's more than 5 corneal dots or 9 conjunctival dots, that would be a positive sign for dry eye. So what we will be doing now is we would change the light to white light, like so. It's quite bright now. And we'd be doing the same thing. So I normally increase the brightness, the magnification, to look specifically for dry spots. So you can blink for me. Sometimes it could be something on the tear film, or if it does, so in this case it went away. So that means that it is from the tear film. And if you look to the other side, yeah, and I just do a good scan around the entire bulbar conjunctiva just to make sure that I don't miss anything. So there's just a couple in there, very, very small, and in there another blink for me. I always ask for extra blinkings to see if there's something on the tear film or not. And then I go back to large distance, because what I want to do is I want to invert that lower lid to see if there's any friction, any lid-wide epitheliopathy. There could be, but we don't know yet. So what I'm going to do is I normally use a cotton bud to invert. I normally use the long one. So what I'm going to do is I'm going to tell the patient to look slightly up. I just place it just underneath the lash line. I bring it down and I press just a bit into the eye. So once I'm here, I'll take the image. So what we're looking here is for the marks line, which is this very thin line. And then if there's any friction that goes into the eye, or how big the length of this is. So we can go even all the way there, and we'd be looking all along the lid. So when we're assessing the conjunctival or corneal or bulbar damage or staining, we need to make sure that we assess it about 4 to 5 minutes after we instill dyes in. So in here we're looking at the marks line, which is the line that separates the mucus part of the lid to the skin part. And we have to make sure that it's thin all along. Once you have that friction or that damage in there, or even in there, that we can see it all along there and going a bit more into the eye, that is telling us that somehow there's friction between that eye and that lid. So the next thing that I do is I'll be looking into doing meibography, which is the shape, the size of the glands, the image of the glands. So for this you need infrared light, and we'll do the same thing. I'm going to do an inversion on that lower lid, and what you do, just bring it down and push a bit in until you have that inversion. So I normally take a couple of images, because sometimes you'll not be able to invert the full lid, but you still need to see everything that's happening. I'll do it also here from the side, just a bit more temporally, just to check all the glands and also the openings of the glands. So I'm looking at different things happening at the same time. So we need to see this for both upper and lower lid. So what we're going to do now is we're going to do an upper lid inversion. So I normally tell my patients to look down to the floor, and then for this one you have to get quite close, but you want to make sure that you can see pretty much all the way to the puncta of the patient. And once you're there, you'll take the picture same way. Then what I explain is not only how the glands look, is that what is important is how those glands function as well. So in here we have just about some shortening of the glands. I don't see a clear gland dropout, I see all of them. But for example, this gland over here seems to finishes down there. This one over here seems to finishes down there. But this is the plane of sight that we're seeing now. It doesn't mean that short glands will not be good or the long glands would be amazing, because sometimes we have long glands and not that much of a good sebum expressing. So the next thing that we'd be doing is expressing, doing the diagnostic expression. Normally you can do it with your finger if you don't have the tool, just for the pressure, or otherwise you can use this little gadget that we have. So So with this little device, what we do is we apply the pressure onto the lid margin at about 45-degree angle, and we apply pressure for about 5 seconds on central, nasal and temporal part of the eye, and we look at the outputs coming out of those gland openings, if they are transparent, if they're cloudy, or if they're inspissated, because this is the same, more or less the same pressure as a blink, and that will tell us how those oils are coming out. So this is the diagnostic pressure, the expression, and then we also have the therapeutic pressure, which is something else. So what we're doing now with meibomian gland or evaluator is we're going to press right onto that lid margin to see the outputs of the oils coming out of the gland, and we're going to express in sort of like 45-degree angle, sort of like that, for about 5 seconds to see the oils coming out, and then we're going to grade the quality and how much pressure I'm putting into. So I normally have my patient looking slightly up, and I just place this right on the lid margin. And then when I press in, I just press for about 5 seconds. You can see all those beautiful oils coming out in there. So all the glands that I've expressed, some of them, as you can see probably in here, they are a bit more cloudy, and yet the glands that I am to express. So I'll be doing that all along the eyelid. And we can also see when the patient blinks, all those oils now coming up. You can still use your Purkinje one image just to see the oils coming out of those glands, or the oils floating on top. We can still see the oils and the pattern. And obviously now they are oily, but they are particulate. As you can see, they have a particulate matter. So that means that there's something with those oils that is not spreading as good as it could. So if you don't have a specific device, you can always count in your slit lamp. Another thing that I like to look once I'm in here is at that lid margin. So I just do a good assessment. I normally bring a bit the lid down to see if there's any telangiectasia, any of those new blood vessels. So sometimes when we have meibomian gland dysfunction or lid inflammation, we tend to have new blood vessels. So this patient doesn't have many. There's probably 1 or 2. So the lid is not too inflamed. And same with the upper lid. So if the patient looks down, I'll just look all around there. We're also looking for any blocking of the glands, or when it changes on size or outputs. You can also do the expression in here by pressing a bit onto the eye. And then when you do the eversion of the upper lid, you would also be looking into the marks line over there.